Okay, everyone, it is just a minute or so after 9 o'clock. My name is Teresa Keene, and I wanted to welcome you all to the COVID-19 Long Haulers and Return to Work Considerations webinar that we are hosting today. My name is Teresa Keene. I'm President and CEO of AgSafe, and so excited to have all of you on this webinar this morning. And I am really just, one of the best things about this position is getting to be able to talk to really smart people and learn lots of new things and be able to partner with some really great businesses. And so today's webinar, it's really co-hosted today by Risico Insurance and Risico Inc. And I was able to connect with Carlos Luna. And Carlos is going to be our moderator for today's panel. And so I just wanted to do a quick introduction to Carlos, and then hand it over to him to lead this fantastic panel today. So Carlos is the Vice President of Marketing and Business Development. He is a trusted advisor and stakeholder in healthcare, claims, managed care, insurance, government agencies, and workers' compensation. He is a recognized thought leader, most definitely, on national workers' compensation issues. And Carlos has a blog, so if you haven't followed Carlos's blog, please do. But it's been published by industry-leading publications such as Work Comp Central, Work Comp Wire, Insurance Business Magazine, Louisiana Comp Blog, and more. So with that, I'm going to hand it over to Carlos to get us started. So Carlos, thank you so very much for partnering with us and bringing this really important topic to our network.
Well, thanks so much, Teresa, for that wonderful introduction. It really is a pleasure to partner with AgSafe and with SRTK Law this morning on this great topic. As everybody can see, I'm doing my best Larry King impression with my fancy microphone here, so excuse this big bulb in front of my face this morning. I'm having to do the telecast from a bland hotel room in Anaheim, California, hence the awesome background, so please forgive me for that. But I'm glad that all of you made it. We have a great turnout this morning. And I really appreciate you guys being willing to spend a little bit of your time with us today. As Teresa said, I personally am extremely excited to serve as your moderator on this very important discussion that I think and know will be equal parts engaging and thought-provoking. As you all know, patients or injured employees, given the name long haulers, in theory, have recovered from the worst impacts of COVID-19 and have tested negative. However, symptoms like fatigue, coughing, shortness of breath, head and muscle aches still remain. As these individuals return to the workplace, employers and healthcare providers, TPAs, carriers, and everybody involved in the care and claim continuum are faced with navigating how to best care for these employees without further jeopardizing their health. Today, we've assembled a group of certainly subject matter experts in various fields to discuss these complex issues and consider best practices to protect your workforce while complying with state-mandated regulations in workers' compensation. So I want to take a moment to welcome you all to COVID-19 Long Haulers and Return to Work Considerations. As Teresa mentioned, my name is Carlos Luna. I work for Risico. We're based in Fresno, California. And for those of you that aren't familiar with Risico, it's a multifaceted organization that provides workers' compensation third-party administration services, managed care services such as utilization review, nurse case management, MPN administration, bill review, and so on. And we also offer workers' compensation insurance products to thousands of customers throughout the state of California. Now, as I mentioned earlier, I'm extremely proud that we were able to get this panel together for this presentation in partnership with AgSafe and SRTK. They're all very accomplished individuals, and they represent various points of view ranging from research and medical treatment We're certainly going to have a wonderful discussion on the employer perspective and what employers are looking at on the front lines. And we're also going to be joined by a legal expert to talk about legal defense and some recourse that perhaps some of you may consider as you're navigating through this crazy landscape of long hauler syndrome. I've asked each of our panelists to introduce themselves. So why don't we start with Dr. Greg Vanichkachorn. Tell us a little bit about yourself, Doctor, and also for the rest of the panelists, if you wouldn't mind sharing with us what you're most concerned about as it pertains to COVID-19 long hauler syndrome. Dr. Vanichkachorn.
Well, thank you so much for having me, Carlos. I appreciate you allowing me to come and speak about this very important topic, and a topic that has dominated my life here for the past year. So my name is Dr. Greg Vanichkachorn, and in the spirit of safety, we typically shorten it down to Dr. Van. And I am an occupational and aerospace medicine physician at the Mayo Clinic in Rochester, Minnesota. I know what you're already all thinking, so I'll go ahead and answer the question. My business and my specialty helps take care of individuals who are having medical conditions that affect their ability to work or are caused by work. And one of those employees, or types of employees that I specialize in, are pilots, typically commercial airline pilots, but also astronauts and general aviation pilots. And so that's where the aerospace medicine part of that comes in. I've been working in workers' comp and occupational medicine for over a decade now. And over the past year, I've had the pleasure of working with individuals who have had work-related COVID-19 infections, as well as the post-COVID syndrome. And I'm here to share those insights with you today. To answer your question about what am I most concerned about going forward regarding the COVID-19 pandemic and workers and post-COVID syndrome, I will go and touch on the post-COVID syndrome part and say that I am still concerned that patients and employees who are experiencing ongoing symptoms from COVID-19 are not getting the support that they need from their employers, their loved ones, and their providers. I worry that we will run out of steam behind this issue as we move out of the pandemic and life gets back to normal, hopefully for a while. And I think that we need to keep raising the spotlight on this condition and hopefully figure out more what is going on.
Well, thank you, Doctor. Really appreciate your input. I'm going to call now on Amy Wolf. Amy, would you tell us a little bit about yourself and then also share with us what concerns you most about COVID-19 long hauler syndrome?
I'm happy to. Hello, everyone. It's good to see you. My name is Amy Wolf. I'm currently the Chief Development Officer for Daniel C. Salas Harvesting. We're an agricultural personnel management firm focusing in the 5 southern counties of the San Joaquin Valley. So we provide skilled technical labor from Madera County down to Kern County, and our employees work in a variety of settings, both in the field, vineyards, orchards, as well as in packing and processing facilities. As many of you know, prior to this role, I was the president and CEO of AgSafe for 11.5 years. And I've spent quite a bit of time working with all of you and understanding the practical realities that we all face as agricultural employers. And I will tell you, in our position, one of our greatest challenges that we're navigating and continue to struggle with is the practical reality of being an employer that provides labor and we don't have total control over how we mitigate the risk and the conditions for our employees, right? Because we're not the owner of the facility, we're not the owner of the property, and mitigating risk and ensuring that not only we take care of our employees, but then we also look at the practical employer responsibilities, particularly in how the state of California has dictated our responsibilities to our workers. It's a quagmire, frankly. I've been looking through some of the names of who's joining us today, and I know, having worked with you over the years, this is hard to figure out. And as per usual, the issues affecting us are unique to our industry, and our industry wasn't at the heart of considerations when the state legislature and various regulatory agencies considered how they were going to structure what we need to do to ensure we mitigate the greatest amount of risk for our employees possible. So for me and for our organization, how we continue to take care of our people and navigate the constant changing environment and landscape is one of the greatest challenges we're having, and that's going to continue. And a little bit later, I'll share one employee specifically that we are working very diligently to support him in returning to the best possible health he can have, and understanding what the right thing to do as good people, and how we do that in an environment where it's a moving target in terms of what we have a regulatory and a legal obligation and a responsibility to do is proving to be a challenge.
Thanks so much, Amy. Looking forward to your portion of the presentation. Lastly, I'm going to call on Mr. David Chun from SRTK Law. David, would you tell us a little bit about yourself and then also share with us what you're concerned most about COVID-19 long hauler syndrome?
Sure. Thank you, Carlos. Thank you to AgSafe and Risico for inviting me and giving me this opportunity. I've been with SRTK now for 22 years. I've been practicing workers' compensation defense for 23 years. I'm a certified specialist in this area of law. I'm also based in Fresno, so a fellow Fresnan along with Carlos. I've been out here in Fresno since 2007. So my bread and butter practice areas are construction, ag, and hospitals. When the COVID pandemic hit, a lot of my ag companies, clients, they called on me to strategize, to ask for help, and just to vent and talk things out. And so as a result of that, I've been exposed to a lot of litigated and non-litigated COVID claims. As far as my main concern, it's really the same principle as I've always lived by as a defense attorney doing workers' compensation, which is to balance the rights and obligations of my employer and insurance carrier clients with the state mandated fast track benefits that employees in California are entitled to. So the mantra of, I want to make sure that legitimate claimants get what they're entitled to, but not a penny more. And so that has posed a very interesting dynamic when it comes to a pandemic. What is caused by work and what was caused by something outside of work, especially if it's all over the world globally. So I'll touch on that some more during my presentation, but really to protect my clients' interests while also recognizing that there are legitimately injured people as far as the COVID pandemic goes.
Thank you, David. You're a wonderful addition to the panel. I'm sure that there are some individuals, some employers that are wondering what type of recourse they have is available to them from a legal perspective, taking into consideration the vast amount of regulations that states have adopted pertinent to COVID-19, presumptions, and so on. So we're certainly glad that you're part of our panel today. Now, for the general audience, we've compartmentalized today's presentation into two elements, or three segments, rather, I should say. Those three segments will start with the research and medical perspective. We're going to dive into the employer perspective following that. And then we're going to end off with the legal perspective and legal portion of the presentation. You should all be aware there are CEUs available. So if you are interested about obtaining your CEU certificate for this presentation, be sure and send us your name and contact information in the chat box, and we'll be sure and get you that certificate courtesy of SRTK Law. Without further ado, let's go ahead and dive into the meat of this presentation, starting off with Dr. Greg Vanichkachorn, who is going to share with us from a research and medical perspective what it is to deal with COVID-19 long hauler syndrome. Doctor.
All right, well, thank you again, Carlos. So looking back at this past year, I think everyone who is in this presentation can agree that the COVID pandemic really has brought on more challenges than any of us could ever have imagined, both at home and at work. And we could spend the entire day talking about all of these different hurdles, but of course the topic at hand is the things that we are facing now in occupational medicine and in workers' compensation. As I mentioned earlier, I've been working in this field, treating patients with work-related conditions for over a decade, primarily out in Montana before I came out to the Mayo Clinic in Minnesota. And before the COVID pandemic, I had very rarely ever treated a work-related infection. But now that has all changed with the pandemic. As we struggled to keep society moving forward during the pandemic, the plight of frontline workers, healthcare providers, teachers, and so forth, and also essential workers was highlighted in society. And to protect these individuals, many states adopted measures that allowed for COVID-19 infection to be related to work. And bolstering this, there was also a lot of contact tracing going on, either being done by hospital systems, including Mayo Clinic or local health departments and so forth. And this made it easier for information that is necessary to relate an infection to the work site to be more accessible, even for those individuals who were exposed at work and didn't even know it. So with that, since COVID-19, work-related infections have become quite common, at least in my clinic and practice, and we're now facing what I would call a new Pandora's box as we go forward in occupational medicine and workers' comp. Next slide, please. Oh, so there. And to complicate matters further, we are also dealing with a condition that can have significant work loss. Initially in the pandemic, it was estimated that individuals that would need time off of work for COVID-19 infection would just require about 2 weeks normally. That is the normal isolation period. Of course, if you were in the hospital, your recovery may be longer. But now, as we have seen over the past several months, there is the new long haul COVID, or what we call post-COVID syndrome here at Mayo Clinic, that can result in individuals having extended time away from work, sometimes several months to even a year or more in some of our cases. These two factors, the increasing prevalence of work-related conditions and the possibility of now prolonged work loss associated with COVID-19, have had significant impacts on several industries and employers. Just as an example, I'll give some information from my industry in healthcare. It's important to remember this is not the actual first coronavirus outbreak that we have seen. There's been SARS and MERS in 2002 and 2012, respectively, as well as some other smaller outbreaks, including zoonotic outbreaks. And from studies in that, we know that healthcare workers in particular can be affected by the coronavirus infection. So for example, in a study of the 55 hospitalized patients who had SARS, looking at how they did after 2 years from their infection, 7.1% of individuals who are non-healthcare workers, sorry, a little bit of a typo there, 7% of non-healthcare workers were still not back at work due to prolonged symptoms. Conversely, about 30% of healthcare workers had not been able to get back to work. And so we had seen in that infection that healthcare workers, because they're on the front line, tend to get more or have more difficulties with recovery. Next slide. And this is a trend that we have also seen in the current COVID-19 pandemic, and in fact, worse. In a study of roughly 3,800 healthcare workers in the United Kingdom, looking at how they did 4 months after their infections, 45% of those healthcare workers reported having severe ongoing symptoms such as fatigue, shortness of breath, and sleep disturbance. So as you can see, the profound effect that COVID-19 can have on work loss and industries is quite staggering. Next slide. And so it's because of these challenges that I became involved in the care of patients recovering from COVID-19 early in the pandemic. The question I often get a lot is how did occupational medicine take up this mantle? So early on, even before the pandemic, our division here had been tasked with helping individuals who had medical conditions and were in the ICU get back on their feet and, of course, get back to work. And because of that, it was natural that once patients with COVID-19 who were in the ICU were coming out of the hospital, we got tasked with helping these folks as well. And pretty much from the get-go, we started to notice that individuals who were coming back from COVID-19 were not having an expected recovery. And to help out these folks, we assembled a group of different specialists from fields such as pulmonary medicine and infectious disease and cardiology to come up with a plan to help treat these individuals. And as more and more patients reported having difficulties with their recovery, we formalized this program into what we call the COVID Activity Rehabilitation Program, otherwise known as CARP, roughly in June of 2020. And since then, we've had more and more patients, and to meet that volume, we've also developed now a post-COVID care clinic that is focused on helping individuals who are still experiencing symptoms 3 months out or more from their infection. And with this, we have seen several hundred patients from all across the United States using a combination of both in-person visits and telemedicine to help them with their recoveries and understand more about what they're experiencing. And so there have been a lot of articles and media reports out there about long haul COVID, but not so much from the perspective of clinical providers. And so I'm going to spend the rest of my time this morning just sharing a little bit of some of the nuances that have come to appreciate, especially from an occupational medicine standpoint in long COVID. Next slide, please. So what are the symptoms that we see? Like other reports out there, the most common symptom we see is fatigue. And this is not like other fatigue. For example, patients will state that they will do things like take out their trash or go for a walk around their home, and then they will have to take a nap for several hours or even be fatigued for several days afterwards. We've had some patients who are unable to even bathe after their infection. We also hear about respiratory complaints quite a bit, and this is not surprising, as we know that coronavirus infections, even without any other symptoms, can cause prolonged troubles with wheezing for several months. Prolonged problems with shortness of breath for several months. What is surprising to us is the amount of neurological and cognitive problems we have seen in our patients. 45% of patients reported having some trouble with their thinking. This is commonly referred to as brain fog, and difficulties with things like short-term memory, word finding, and multitasking. This is important to note because of all the symptoms that patients are experiencing. I find that it's the cognitive impairment that causes the most problems at the work site and with work. You know, it's easy for employers to understand if someone is suffering still and needs time to recover, if they, for example, are wheezing and using oxygen. But when someone has cognitive impairment, there's usually nothing on the outside that can guide someone else to understand what that person is experiencing. All they see is the ramifications, which is typically troubles doing typical work activities. In addition to that, we also saw quite a bit of sleep disturbance, and roughly 25% of our patients reported some form of clinical mental health complaint like anxiety and depression. Next slide. And I want to highlight a little bit that 25% there. Again, that's just the individuals that reported having severe anxiety and depression. If there's one universal truth that I have found amongst all patients with long COVID, it's that they feel abandoned. And it's easy to see how this may have happened. This is a very new condition. A lot of providers and patients and society in general do not know about how this condition can affect a person's life and what the symptoms are. And so patients are often told things like, this is all in your head, or you just need to tough it out, or why should we treat you any differently when all of our other employees have been able to get back on their feet normally? And because of this, patients often feel quite a bit of guilt and self-doubt, and that leads to clinical depression, anxiety, and even post-traumatic stress disorder in some of our patients. And consistent with this, studies of patients who are recovering from COVID asking what they felt they needed to help with their recovery, 12.9% have reported needing some form of psychological support. So one of the first things that we do for treatment of these individuals in our clinic is that we empathize with them and let them know that what they are experiencing, we have seen in hundreds of other patients at this point, and that they are not alone. But at the same time, it's important that we don't medicalize or catastrophize their condition with them. I think we can all attest to what has happened to individuals who have told that their low back injury is going to be life-changing and that they'll never get back to work. So it's a fine line that takes a certain skill set. As for function, we also see some deficits that are consistent with the previous coronavirus outbreaks. In our patient population, we look back at the first 100 individuals that we have treated. 34% of those patients reported having difficulties doing some of the most basic activities of life, just like getting dressed or brushing their teeth or using the bathroom. In addition to that, 82% reported difficulties with the more meaningful things in life, such as driving, household chores, and of course, work. 63% of our patients had been able to get back to work in some form. However, less than half of those were back to their normal full-duty work before their infection. 1/3 were not back to work in any form, and the average time to presentation for our patient population was 3 months out from their infection. So you can see that this is having some profound effect on workforce and the ability to work. Next slide. Oops, sorry, there you go. So the big question I often get is, why is this happening? And you know, is this all really just a mental health condition, or is there something else? I, for the record, do not think that this is purely a mental health condition. I do think that the mind and body work together and both need to be addressed, as I mentioned earlier. There are several hypotheses out there at why this may be happening. We do know that early in the COVID-19 infection, there can be this cytokine storm, basically a overdrive of the immune system that can lead to the body essentially attacking itself and having immune dysfunction. Consistent with this, we have seen markers of inflammation be elevated, including things like interleukin-6 in some patients. There's also been an increased amount of autoantibodies. There's also a theory that this may be related to what's called mast cell dysfunction, and is related to some of the effects that we have seen in children, but is also now recognized in adults. Next slide. And the more that we study this condition, we also think this is more of a neurological condition than we previously thought about. Everybody was so focused on the respiratory problems early on, but what we have found in our patients here is that there is a great amount of neuropathy, including autonomic neuropathy and small fiber neuropathy. In fact, of all the tests that we perform on patients who are recovering from COVID, it is the autonomic testing that is most frequently abnormal. Now, the important thing to note about all of these things that I've just said is that these are currently hypotheses still. We do not have basic research right now to understand what is going on a biochemical level. This is slowly trickling out, but just to give you an idea of how far behind we are with understanding this, there's been a huge funding opportunity released by the NIH recently. And the primary purpose of this funding is to really just understand what is the presentation of this syndrome, not the underlying chemical processes. So we've got some time to go before we can really figure out what's going on in the chemical level. Next slide. As for diagnostic tests, I was asked to comment on this because I know this has great relationship to workers' compensation. When patients came into our clinic early on, we of course did every test that we thought could be potentially beneficial. So echocardiograms and pulmonary function tests to assess how the lungs were working, and chest x-rays. And as you can see here, this is data from our first 100 patients. These diagnostic tests were actually not quite helpful at all. Of all the 35 chest x-rays that we did, only one was abnormal, and it was barely abnormal. The pulmonary function testing was also, for the most part, all normal, with only slight changes to account for the 7 individuals that were quote unquote abnormal. So we do have a philosophy here in our treatment program that less is more when it comes to diagnostic testing. And we start off with just a few basic blood assessments for patients who present initially with COVID-19 recovery issues. As for remedies out there, we constantly get asked if there's a quick fix, if vitamin D or ivermectin or taking Zantac will cure this, or if the COVID vaccine will cure this. Unfortunately, we have not found such a quick fix. All of these things here that I have listed are remedies that have been touched on in the media. But right now, before we can recommend those things, more research needs to be done. We have tried a few things here and there along these lines to help patients, and we have not found a consistent improvement by using any of these. But hopefully, again, as we get more involved in understanding of the chemical processes at play, we will find some treatments that are available. Most of the treatment from our clinic's perspective is helping patients recover and recondition in an appropriate fashion using physical therapy and occupational therapy. Next slide. Oh, go back, sorry. So just to give an idea of what the outcomes look like for patients who are trying to come back from recovery, we did go back and look at our first 100 patients, and these are the observations that we made. This wasn't a randomized clinical trial, but this is what we have seen. 20% of our first 100 patients made a full recovery, and we only counted those who got back to full duty work. So these included individuals who, again, were not able to walk across their bedroom or take a shower without having to rest. And they were able to get back to full duty work, including laborious work for some of those individuals. These individuals seem to have recovered about 4 months after their acute infection. We also noticed that compared to the rest of the population, they had an earlier start to their treatment, usually about 30 days after their infection. They also had less cognitive complaints than the rest of our patient population, again, highlighting the brain fog and its potential impact on the ability to return to work. So these are, again, observations, not inferences, but I do recommend that if patients are having difficulties getting back on their feet after COVID, they seek care and treatment earlier on in their recovery period. And so this is a slide that I always like to throw in just to kind of finish up and give an idea of the dilemma and challenge that we have ahead of us. As of, I guess, 2 weeks or last week, there have been approximately 29 million COVID-19 cases in the United States alone. Based on our current research, we estimate conservatively that 10% of individuals who have COVID-19 will come down with post-COVID syndrome or prolonged COVID. That's 2.9 million. Based on our other research, we know that approximately 30% of individuals with post-COVID syndrome will have difficulties getting back to work. When you do all the math together, that's about 870,000 people in the United States who will be out of work for several months due to post-COVID syndrome and their COVID-19 infection. And these are not just nameless people. These are teachers, laborers, physicians, and so forth. And so the post-COVID-19 syndrome and COVID-19 pandemic challenge is not just something that's for healthcare, but something that's going to affect our society, employers, insurances, and a challenge that we're going to all have to work together to get around.
Well, Dr. Greg, thank you so much for that data, for that information. Please keep us posted, you and I. Let's stay connected as more research is done on other segments of the working population so that we can keep the good folks at AgSafe and their constituents informed on the developments. We're going to transition over to the employer perspective now. And so I'm going to hand the time over to Amy Wolf, who's going to walk us through an actual claim that they're having to navigate. By the way, if you have questions for the panelists, also include them in your chat function of Zoom, and we'll try and answer as many of them as we can prior to the conclusion of this presentation. Amy.
Thank you, Carlos. So I think at this point, as an organization that employs roughly 3,500 individuals on an annual basis, we consider ourselves fairly lucky that as of right now, we only have one identified long hauler case. Let's move to the next slide, please. So I want to give the group an overview of this employee and then talk a little bit about where we find ourselves today in terms of continuing to provide him support. So this is an individual who is 70 years of age and has been with our organization for over 20 years. He has spent the vast majority of the time with our organization working in a packing shed and has held various capacities that include strenuous physical labor, lifting over 50 pounds, lot of repetition, lot of the kind of work that, it takes its toll on you physically. but until he contracted COVID, had never had a documented workplace-related injury or illness, and frankly considers himself an incredibly loyal individual to our organization, which is part of some of the struggle I'm going to talk about here in a second. This individual tested positive for COVID-19 back on June 29th of last year and ended up being hospitalized for 37 days with acute respiratory failure. And to our knowledge, and based on the information that's been provided to us as part of the claim, he did not have any pre-existing respiratory related issues. So wasn't an asthmatic and hadn't experienced any other respiratory related health challenges, again, to our knowledge, and I should say to his knowledge as well. Next slide, please. So was released from the hospital in August of 2020 and frankly has been struggling since that time. You know, a couple of the comments that Dr. Van had made in particular in highlighting some of the symptoms that long haulers are experiencing line up like textbook with what this employee is struggling with. He is easily winded in a general conversation, and that is a symptom that has failed to meaningfully improve since his release from the hospital almost a year ago. We are in regular communication with him in part because he continues to also reach out to us. That's included ongoing telephone conversations as well as in-person visits. And one of the things that continues to strike us is just how limited he is from an energy perspective. He gets worn out talking to us on the telephone, and visibly struggles when when our safety manager has sat down and met with him in person. And that includes as recently as the most recent doctor's visit he's had, which was 2 days ago. He's been on total disability. He was on total disability up until May 14th. Next slide. And on May 14th, he was released back to modified duty. And we have been in serious conversation with medical professionals to question this decision. The restrictions are that his work must be part-time only. He always has to wear supplemental oxygen. So were we able to provide him with modified duty, which at this point we are not, and I'll speak to that in a little bit more detail here in a second, he must continue to wear supplemental oxygen at all times, and is doing that round the clock in his home as well. He is prohibited from lifting more than 5 pounds. And as I mentioned previously, this is an individual who has worked for our organization at a packing house for over 20 years, where regularly he is lifting in excess of 50 pounds. And he must take a 5-minute break every hour. So any of you that are participating that are on the production side of an agricultural operation, this is near impossible for us to make available to him on a consistent basis. We've had lengthy conversations internally around having him come into our office to do clerical work. But from a practical perspective, this is an individual who is a non-native English speaker, who has limited literacy capacity. And to be honest, we are severely limited in what we would be able to have him do in a clerical capacity within our office that would consistently provide work for him. Not to mention, we are pushing back on the transition into a modified duty diagnosis, because the fact that he is worn out talking to us leads us to believe that these restrictions are untenable, that this isn't practical for us to be able to provide to him. And it concerns us about his physical health. And I think this speaks to some of what Dr. Van spoke to, and I think is an ongoing challenge that we as employers are going to navigate, which is the medical profession is still struggling with how to progress these individuals into a position that allows them to potentially return to work. And I will tell you, this is an employee who has been pushing hard for the doctors to let him come back to work. Next slide, please. So, one of the practical realities that we are navigating is, number one, we don't have positions within our organization that lend themselves to accommodating him. He is certainly not in a position to go back and even provide clerical support at the location where he has worked for over 20 years. There's dust, particulate matter. We believe rigorously that even providing him clerical support on site, it's not even an option. It would aggravate the fact that he suffered acute respiratory failure and continues to have the respiratory challenges that he has. But on top of that, again, we don't have, this isn't someone that we can ask him to, file paperwork, right? That necessitates a possession of written and literacy skills that he doesn't possess. We've worked with our insurance agent to talk about things like, is he serving in a sanitation capacity? Is he, serving in an advisory capacity, monitoring hand washing and supporting our additional COVID risk mitigation efforts? No, I mean, the fact that this gentleman is got to have an oxygen mask on, has to have supplemental oxygen at all times, is winded and easy, just how are you doing? What's going on type of conversation. Our hands are really tied. And again, we question whether he should have even been put back into a modified duty capacity at all. Next slide. So his next doctor's appointment was 2 days ago, was on Monday. And we are still in that struggle where our safety manager picked him up, took him to his doctor's appointment, sat in the waiting room, but asked to have a conversation with the medical staff to say, we really are asking that you revisit your return to work parameters. And the doctor flat said, this employee is not acknowledging and understanding that he is not healthy enough to go back to work. But this is where I think for those of us that work in production agriculture, we understand we have a very real cultural as well as generational challenge that we're navigating. This gentleman is of an age and that working is what he knows. It is all he has ever known. He is struggling significantly with not being able to work. And so I feel like the doctor is in a catch-22 because I think the doctor has given him this restricted duty as a means to placate our employee, right? Because he's becoming agitated, frustrated, combative might be too strong of a word, but our employee is pushing the doctor hard to be allowed to go back to work. He has expressed to our staff on multiple times that not working is a problem. It is an embarrassment, and he needs to ensure that he is providing adequately for his family. And while he was on total disability and was receiving appropriate payments accordingly, that's not the same thing as, in his mind, doing what he should be doing, which is working and providing for his family accordingly. And so we find ourselves, as is often the case with workers' comp claims, that this challenge is not unique to a long hauler's COVID situation, but we do find ourselves, in this push-pull with the medical provider around keeping him at a status that we believe is appropriate, given the signs and symptoms that he's exhibiting. And again, he falls into the classic, most common symptoms that Dr. Van articulated, particularly around fatigue, as well as obviously respiratory issues, and in particular in his case, because this was from acute respiratory failure. But not wanting to ensure that that he's receiving proper care and that we're not being pushed into a scenario that it's untenable. We cannot accommodate this modified duty and won't at this stage of the process. But having the medical provider in response back to us say, our hands are kind of tied, we are very much in a wait and see mode. There isn't additional therapies beyond the medication that he's already being provided, as well as, again, supplemental oxygen. Like, this feels like the worst possible holding pattern that we could be in. And we're having our medical providers sort of, raise their hands in the air and say, there's nothing else we can do right now. He has not meaningfully improved since his release from the hospital last August. And so for our team, we're in weekly communication, we're attending doctor's appointments. We are in agreement and pushing back that modified duty is not feasible. But there's this helplessness around, okay, so now what? I mean, is this going to be the open claim for years because he is not showing any meaningful progression in terms of responsiveness to the therapies that have been provided to him to address the respiratory issues, the fatigue issues. And, you know, and sort of where do we go from here? I even find myself wanting to ask Dr. Van, what should we be doing differently, if anything, because we are struggling with, you know, aside from wanting to assure we are attentive and wanting to assure we are responsive, but drawing a very hard line in that this cannot be accommodated, and wanting to advocate that, in fact, the doctor is really making the right medical call. I sometimes wonder if the conditions that were placed were the doctor's way of giving our employee a little bit of something, but certainly created conditions such that we as the employer cannot accommodate. And he knew that, right? But he's trying to, you know, he's trying to help, you know, trying to be responsive to his patient, who is being very determined and demanding and insisting he have the opportunity to go back to work. So he has monthly doctor's appointments. His next doctor's appointment has been scheduled for, I think, July 23rd. And again, it's starting to feel a little bit like Groundhog Day, and has for a few months now, but certainly for the last 2 months, when his total disability status was transitioned into a modified duty option that is not possible. So I'm sure what I'm saying resonates with everyone. You know, some of my key takeaways, you know, continued communication. Like I've said, we are in weekly communication with this employee, and that is included in-person visits as well as having conversations with him on the phone. I will comment as well. Getting a hold of him on the phone became a challenge because he was sleeping so much, because the fatigue issue is real. And so about 6 months ago, that actually brought about our staff going to see him in person, because we had this window where we were getting very concerned that we couldn't get a hold of him. And so that's when our safety manager made the time, jumped in the car, drove to his house to check on him, and saw for herself the extent of the issues that he's navigating in terms of his fatigue. So yeah, Dr. Van, if you've got any ahas, I actually welcome them as well. But just sharing with everyone, communication is critical, and doing what we're doing and pushing back and saying, this isn't a viable option. Help us in coming up with all other ideas. I think the struggle in all of this is there aren't any other ideas right now. Our medical provider doesn't have other ideas. And so I think this holding pattern that we're in is as good as it's going to be until, frankly, the medical field begins to, you know, like, we're living this in real time and don't have, even with MERS, even with SARS, and even with some of the other aeronautical diseases that we've navigated as professionals, I still feel like, you know, this is the first chapter in the first book in a series of books that's being written about how we navigate caring for these issues. And so, not that we're making it up as we go along, but there is an element of this around wait and see. And that's, I know that's incredibly frustrating for employers, but, you know, that's sort of where we find ourselves right now. So.
Well, Amy, thanks so much. And by the way, I am going to put Dr. Van on the hot seat here in just a couple minutes. So get ready, Dr. Van, it's coming your way. There are a couple of things that you said, Amy, that really stood out that I want to commend your organization for doing. One is your constant communication, not just with the employee, but with the provider as well. And so I think the communication throughout the claim continuum is going to be key. And I think you guys are way ahead of that. And I think that there is likely very little gray area as it pertains to where you are and what tomorrow holds in terms of you know, the claims process. So kudos to you for that. The other thing that really stood out to me was your approach with empathy for this employee. The individual has worked for a great deal of years for your organization. Clearly, your organization values this individual not just as an employee, but as a friend, right? There are certainly work relationships that develop over the course of time, and it sounds like there are numerous individuals that work for your organization that are sincerely concerned for his well-being. And I think that really stands out throughout the care and claim process as well. I've said it many, many times, those of you that are watching this webinar that have followed my career, I've spoken on employee advocacy many, many times, and its efficacy. And this is something that I would say, Amy, you continue on, you stay on that path. It is going to make a difference. The waiting game is tough to wait out, right? But you guys are on the right track as it pertains to your involvement on the claim side of things and your involvement with the employee directly. The third thing that I would point out, and this is where I'm going to really ask Dr. Van to give us his advice. Let's take off our professional hats for a moment. Let's just have, some informal dialogue here. So we're not going to hold you to the fire on what you say, Dr. Van, even though it is on the record. We're recording this, but just know that we're not going to hold you to it.
I'm never a professional anyhow, so it's okay.
So we want, we're having virtual cocktails right now, unreal virtual cocktails. There's actually coffee in this cup and nothing else. Mm-hmm. Wink, wink. Mm-hmm. Anyway, so the balance that we have to navigate as it pertains to time away from work, and you and I have presented together on this topic before, Dr. Van, and how disability can be exacerbated because of time away from the workplace, right? And in this case, you have an individual who clearly is motivated. This is the Peyton Manning of agricultural workers. He wants to work, he wants to get better, he wants to do well for himself, for his family, and for his employer. He's highly motivated. It sounds like clearly the guidance that the provider who is seeing this patient feels that, to some degree he's ready to be in the workforce, and so has developed a modified duty plan for him to be able to be back with his colleagues at the employer's workplace. We've heard very clearly, without any chance of misinterpreting Amy's frustration with that, because accommodating that modified duty is nearly impossible, if not totally impossible. So here's what I'd like for you to give us guidance on, or your advice, your personal advice. How do you balance that, right? How do you balance that?
Yeah, this is a very good question. And let me just start off first by also agreeing with you, Mrs. Wolf, about your support of the employee, because this is the first barrier that we often see, and your organization's support of the employee is not something that we see quite frequently. As I mentioned in my presentation piece, what I often hear is that patients get compared to other employees, and not everybody gets this, 30%, right? And so, or 10%. So most of the folks in the work site who've had COVID-19, they get back to work, and it's fine. And so it's very difficult for them to get any understanding from their fellow employees or supervisors, sometimes even their family members, which can be tough. So thank you for that. All right, so, I often call myself a hard drive, because I'm in the business really of reformatting a lot of things for patients. And I've heard this quite a bit. You would think, based on some of the other conditions that we've seen in workers' comp, that there would be a lot of people who are really angry about getting back to work and don't want to get back to work and want to play the victim role, but I actually have not seen that at all in this situation. Most individuals are eager to get back to work, and they're very worried about what the future is going to hold for their employment, and that sometimes drives them to move forward. Unfortunately, what I've seen, in particular with this condition, is that pushing someone too hard to get back can actually put them back quite a bit. And in fact, this is why most people end up coming to us, or the state that they come to us after about 3 months. So this fatigue that people get, they will experience this because they are eager to get back on their feet and get back to normal life. So they will try to do something, whether it be go back to work, go for a jog, or take the dog out for a walk or something like that. And then they have this fatigue. This is a type of pattern we have seen in other possibly related conditions like chronic fatigue and fibromyalgia. And it's called post-exertional malaise. And during that time period, it's not just someone being tired, but we think that there are chemical changes that go on, more inflammation or immune dysfunction, and this results in another insult to the body. At the very least, the patient is sleeping now and resting for a couple of days. They get more deconditioned, and then they want to get back to work again because they're rested up. And so they try again, and then they go back and forth until they're just totally demoralized, deconditioned, and they really don't have any chance of getting back. And so that kind of sounds similar to what this gentleman is unfortunately experiencing. Now, the way I typically reformat this scenario for patients is their work restrictions to me are actually what I call life restrictions. And I go through them with this. Yes, I'm going to write down on this form that's a work status form that says you might be able to do light duty work for this many hours in a day and so forth. But you also work in a place where this is not going to be very feasible. It's a safety sensitive environment. And sometimes I compare them to careers in pilots, right? Like if I had someone who had a stroke, I couldn't tell a pilot to be like, well, just fly the takeoff portion of the flight and then someone else will take over and everything should be fine. It's an all or nothing type of situation. And so what I do is I remind them that what they are doing at home, especially if they're in therapy, is quote unquote part of their work as well. So if they can't get back to the work environment because of the work restrictions, that doesn't mean that they're not working. This is part of the plan that their employer has agreed to, that we have been trying to help them with. And so meeting all of those therapy appointments, doing their home therapy regimen, simulating work activities at home is all part of the process. And we key in on those changes every time a patient revisits with us to see, okay, what's the latest? You know, were you able to do the laundry? Were you able to walk up 2 flights of steps? How far have you been able to walk down the block this time? And that helps the patients realize that they are making progress and that we're getting towards this goal of ultimately getting them back to their work site. So for a lot of patients, it's been, you know, okay, I can't really recommend, or they can't really get back to work with having breaks, for example. And so when it does come to that point where they've progressed enough based on what we see at home and in therapy, that they could get back to work with more of just a time restriction, that then we'll release them back to what's called titrated hours. So I would say for this individual, getting him back on his feet to the point where he can work 2 or 3 hours at a time, maybe 2 or 3 days a week to start off with for about 2 weeks, is a good way to sort of ease him back into the work environment. And then we'll know if he's able to work in the packing shed for 2 hours without any difficulties, then we can bump it up to 3 hours, 4 hours. That does take some juggling, of course, with the employer and the supervisors. But with the right kind of environment, that's how we typically approach this. Work just doesn't happen in the workplace for these individuals.
Thank you so much for that elaboration, Dr. Van. Certainly a complex situation. I think you guys are on the right track, Amy. Keep us posted on it. I think that the general audience would love to know the outcome of it. As we switch forward to the legal aspect of our presentation, I'm going to call on Mr. David Chun to provide us some guidance on what type of recourse is available or what type of paths are possible for employers having to deal with post-acute COVID syndrome. David?
Thank you, Carlos. So let's just go right to the first slide that talks about the outbreak statute. Okay. Most of you have probably seen this. If not, let me just tell you that this is the statute that most employers with more than 5 employees are dealing with. The executive order that Governor Newsom had issued before this was codified in 3212.86. 0.87 deals with first responders. And so for probably everyone on this call who are employers, this is the particular statute that applies. I'm not going to spend a whole lot of time on these particular things, but I want to lay a foundation because some of the more practical things that I will talk about a little later is based off this foundation. So the criteria is more than 5 employees. If there's an outbreak as defined by the statute, and it's based on an outbreak within a specific place of employment, the date of injury, which is the last date of work, is on or after July 6, 2020. And there's a 45-day decision period, meaning that the typical claim has 90 days that you all know about, but this particular statute only has a 45-day waiting period to accept or deny a COVID claim. Next slide, please.
Now, David, just to clarify, this labor code is for the state of California. For those of you that are joining us from outside the state, I did see some names from my friends out in Maine So welcome to the webinar. This labor code is specific to the state of California.
That's correct. Thank you, Carlos. And the statute further goes on to define what an outbreak is and when it has to occur. So the outbreak as defined needs to have existed either 14 days before or 14 days after the last date of work, which again is the date of injury. And it's defined differently depending on how many employees over 5 the employer has. If you have less than 100 employees at that specific place of employment, an outbreak is defined as 4 employees testing positive. If there are more than 100 employees at that specific place, it's 4% of the employees testing positive. And the other criteria is that there needs to be a positive COVID test within the 14-day period. And the test has to be of a type that shows an active virus. So it can't be just a serologic test that shows antibodies and not an active virus. Next slide, please. Here's what all of you who represent or who are employers on this call are interested in, which is that within 3 days, 3 business days of finding that an employee tested positive, you're obligated to report that positive test to your third-party administrator, your claims administrator, whether it's in-house or an outside party. And unless the employee testing positive is claiming a work-related injury or disease, personally identifiable information should not be included. Now, I think this is a good place. You know, I have about 10 active COVID cases in my caseload. They range from the more quote-unquote minor COVID claims all the way to death claims. I do have several long-haul COVID claims, and depending on the severity on that spectrum of the COVID claims, that has really dictated the amount of activity and discovery that has happened on those cases. So for this particular requirement for employers, I have had applicants counsel wanting to subpoena an employer's entire record of all employees who have tested positive, even before finding out whether or not an outbreak has occurred, even before finding out whether or not that particular employee that they're representing tested positive even. So even before they give me a positive COVID test, meaning meeting the other criteria of this statute, they're demanding any on all records of all employees who tested positive. So needless to say, that is just one example of some of the discovery fights that we are having on the front lines of workers' compensation cases. Moving forward, make sure that for indemnity benefits, as well as death benefits, you need to be aware of the rules. Before any TD benefits are due for COVID claims, the employee has to exhaust all other COVID-specific benefits for sick leave. Then and only then are TD or 40 or 850, which is salary continuation benefits, would be due. There is no waiting period per the statute. And real importantly, if an employee dies as a result of COVID, and there are no dependents, then there are no death benefits owed to the death without dependents unit of the state. Next slide, please. So rebuttable presumptions are a little confusing. Okay, let me go through the criteria and then I'll explain what that means. The rebuttable presumption is what it sounds like, meaning there's a presumption if within 45 days, the criteria is met. So the outbreak within 14 days, they have a positive COVID test with an active virus, the last date of work, meaning the date of injury applies, etc. So if an employer and their third-party administrator do not deny a case within 45 days and all of the criteria applies, then it is presumed compensable. But that's not the end-all be-all. After that 45-day period, if you find information that would not have been found or discovered with due diligence within the 45 days, meaning it was legitimately buried somewhere, or the claimant was unavailable to provide useful information, or a witness was unavailable within 45 days, or any of those types of evidence, then that sort of evidence can be used to rebut what may have seemed to be a presumed compensable COVID claim. Okay, so as I'm going to talk about in the following slides, it's really important that employers and their administrators and the legal counsel, that everyone does their due diligence in continuing to investigate and not just assume things. Okay, but otherwise, if it's not timely denied within 45 days and you can't find information to help you deny the claim within 45 days or rebut a presumption before or after the 45 days, then it is a presumed compensable claim. Next slide, please. So this is something that all of you, or most of you probably are already doing. The earliest contact with the situation, including the employee, is very important. But even before that, establishing contact tracing protocols along with your safety protocols specifically geared towards COVID. So it is very evident to me in dealing with multiple employers who was ready or quickly became ready for this as it pertains to workers' compensation claims, and who were not ready. Some of my employer clients took a few months to get ready, and by then, they had already had hundreds of COVID claims. And so a lot of those claims are now either presumed compensable, or the evidence just was not available or could not be found, or are stale and just was not sufficient enough to rebut the presumed compensable nature of the claim. So you see the questions yourselves, but you're asking why. Why does your employee think that they contracted this at work when it is a global pandemic? Okay, even if there's a presumption, you got to keep asking why. Of course, you got to ask about the testing, the evidence of a positive test. How long have you had the symptoms? Have you been quarantined? And if so, by what agency? Okay, next slide, please. These are just examples of topics for investigation and topics for my deposition. If the investigation did not cover all of the topics, travel, shopping, large gatherings, exercise, schools, all of those things that may have lent themselves to your employee being exposed. Okay, really don't leave any rock left unturned. Next slide, please. Really important that you talk about households and anyone else in the household who has been diagnosed with COVID. When were they diagnosed? How close were they? Were they in the immediate household? Were they visitors? Compare the claimant's allegations to the timing and the nature of the diagnosis and symptoms with the family member or the visitor with whom they were in contact. How about statements to coworkers and friends in comparison to what they're claiming in their official workers' compensation claim? How about in-house surveillance about exposure, a claimant saying that they were at this place within the work site, but they were never there. And their claim, the crux of it, is based on them being at that particular location during a period of time. If you have in-house surveillance film showing that they were never there, that would be very important information. Next slide, please. Don't be afraid to use news, Google, LA Times, or the Chronicle in the Bay Area, or wherever you are, to find out if there were clusters of exposure outside of the workplace, at malls or at a bank or at the supermarket. Those could be valuable pieces of information as well. Next slide, please. Now we're talking about not only causation of the actual COVID itself, but the nature and extent of their allegations, as well as apportionment. So for investigation purposes and later on for a deposition, you want to find out about any pre-existing respiratory conditions, things such as pneumonia, asthma, COPD, cystic fibrosis, whether or not they smoked, vaped. All of those things will be relevant to establish a baseline prior to them catching COVID. Next slide, please. The investigation period starts after a claim form is filed. Okay, so that is when you get to formally conduct your investigation. As mentioned earlier, contact tracing, a thorough and detailed contact tracing is very important. I mentioned surveillance already. And one thing from a legal basis that you want to watch out for is trying to qualify COVID as a catastrophic event so they can establish permanent disability under the Wilson case. So under current law, if you have a non-psychiatric claim, meaning an orthopedic or in this case COVID, but then they allege a compensable consequent psychiatric injury, right? Then usually you don't get the permanent disability add-on unless it is catastrophic. So you're going to have applicant attorneys, and I have some in my caseload that try to describe the condition as catastrophic. And certainly some of them will qualify as being catastrophic, as Dr. Greg had elaborated on some of the cases that he has seen. Okay, next slide, please. Hey, Carlos, I have a quick question for you. As far as questions from the audience, do you want me to save them for the end, or do you want me to address them as they come up? I have my question window popped up here.
Yeah, let's definitely wait till the end. Let's get through your content, David, and then we can come back to questions.
Sounds great. Okay. As far as medical legal evaluation, so the early employer investigation and then the deposition, as well as all the other items I mentioned, are setting you up for an eventual medical legal evaluation. Even in death cases, I'm having applicant attorneys demand medical legal evaluations. And so really the issue typically has not been whether or not someone had COVID, because the diagnosis is usually pretty clear, okay? And so some of the fights I've had have been whether or not an evaluation for causation is even necessary, because causation of COVID or whether or not they had COVID is a foregone conclusion in a lot of the cases. It's whether or not that it was work related. And that is often a fact case, as well as a legal scenario, whether or not the presumption applies, okay? So you need to be really wary about pushing for medical legal evaluations or fighting against them depending on what the issue is. But as far as when you get to one, you need to make sure that the evaluator has everything possible. And if there is a factual or legal dispute, they need to know that they are not to discuss those factual and legal disputes. That is for a trier of fact, meaning a judge. Next slide, please. Best practices, we've touched on this already, but really keep track and monitor for TD benefits, 4850, which are the salary continuation benefits, the pre-existing conditions, and establishing a baseline to make sure that apportionment is validly discussed and assessed. And along with the Wilson case, as employers and TPAs and carriers, we need to make sure that there is no unreasonable application of Alvarez-Guzman, where the applicant's counsel and a liberal doctor may try to go out of their way to use different sections of the AMA guides to tack on permanent impairment when there really is none. Next slide, please. There's just some handy dandy flowcharts that my firm has created. It's on our website. If you want, we can mail some to you to have handy. But it's a flowchart for the 0.86, which is the statute that was codified based on the executive order. 0.87 deals with first responders, and 0.88, which is what we have been talking about on the next slide, is also there for your reference. That's it for the content. I do have a question. The question is, as the employer, are we able to ask those questions of the employee, or should we allow the Occupational provider to ask those questions? So I'm assuming that a workers' compensation claim has been filed. If a claim has not been filed, then there are HIPAA and privacy laws that would apply. And even if a claim has been filed, there are some, but in California workers' compensation, when someone files a claim and makes specific allegations, then those medical issues are open game for an employer to ask certain questions, okay? And so when you're talking about the allegations of work relatedness, where the employee worked, for the most part, where they have been, who they think they were in contact with as far as contracting COVID, and all of those things that deal with contact tracing and the issue of causation and work relatedness are fair game. Now, if there's a blend of medical privacy issues along with the factual issues, then I would say contact your legal expert such as me or your claims administrator and talk it over with them to see if it is safe for you to ask those types of questions. But I would say sooner the better. Don't wait because you're anxious or fearful that it might be a privacy issue type of situation.
Thank you, David. And this is a great reminder to the general audience. If you have a question for any one of our panelists to revisit some of the content that they've talked about on the research or medical side, on the employer side, and certainly on the legal side, now's your opportunity to type that into the chat. We do have a couple in there to address. Before we move any further, I do want to acknowledge Dr. Van and I. Dr. Van, we need to update our LinkedIn pictures. We've got a little bit more gray in our hair these days than what our pictures are showing. So we'll need to work together on that.
Yeah, I ran out of the black spray paint, so it's more natural looking now.
David looks younger in person than he does at his photo, and Amy just looks flawless. That's amazing. So I do have a question for you, Dr. Van. It looks like somebody from the audience is curious whether or not all the patients that you were referring to in the data that you presented earlier were ICU patients. Can you tell us a little bit more about the patient population that was included in those numbers?
Yeah, so surprisingly, no. I know there's been some talk out there that individuals who have been in the hospital and the ICU are the ones who really get post-COVID syndrome, but 75% of the patients that we have seen in that study, as well as continuing onward, and we've seen probably about 300 to 400 patients now, have not been in the hospital because of their acute illness. And so they were able to manage their symptoms at home, maybe visit the primary care provider in their local area, and that was about it. So from our perspective, we do not see that being in the ICU is going to make you more, that's a requirement for getting post-COVID syndrome. Now, we have had some patients who've come out of the ICU. Those individuals do tend to have a little bit more severe course of post-COVID syndrome. For example, sometimes they're coming out using oxygen at home, which they didn't do beforehand. And so their recovery can be a little bit longer, but those cases are definitely rare compared to everyone else. You bring up a good point with that question. We've all been looking for risk factors. Again, a lot of folks are told that this is all just a manifestation of depression or poor health status, but very rarely do any of our patients have any kind of pre-existing cardiovascular or lung disease, about 25%, same for pre-existing fibromyalgia or depression or anxiety. And we also have a lot of sort of super individuals who are marathon runners, military special operations folks, aviation pilots and things like that, who are quite healthy before their COVID-19 infection and still come down with this.
Thank you for breaking that down for us. Again, to the audience, if you're looking to ask a question of our panelists, feel free to type it in. I have a question for Amy, if you don't mind. So I really admire the culture that you've created around workers' compensation and claims management within your organization in the way that you have interacted with your employee throughout, this long hauler case. Do you have any advice for other employers that might be on the webinar today, Amy, about how they can go about starting to develop that culture if they currently don't have that, and some of the benefits in having that culture that your organization has seen over the years?
Yeah, no, I'm happy to. So I think there's some practical elements to it. We have 3 dedicated full-time staff whose responsibilities are related to our workers' comp claims. And so the pragmatic element of resources and working in an organization who is willing to dedicate the resources to having staff whose responsibility is to be in communication, to support and to track and monitor what's happening as part of the claims process. And frankly, knowing our industry like I do, that could be one of the first challenges folks who are participating today are navigating. You've got staff who are spread too thin. We've got folks who will wear a safety hat and a human resources hat, a safety hat and a food safety hat. And so I will say dedicated resources is, in my mind, the first area that has assisted us. And we're in the business of people. So I think that's part of how our organizations, the mindset within the organization has been, we are in the business of people. And so taking care of our people is critical to continue to be successful in our business. A couple other things to consider. Our team meets every Friday to review all of our open claims. And so one of those 3 individuals maintains an internal digital document where we are internally tracking claim status. We are internally tracking our processes about who has been in communication, who has been accompanying. And so while we certainly, and this is another piece, while we certainly leverage the incredible support and resources provided by our agent as well as our carrier, we don't solely rely on the resources made available to us through our agent and our carrier as how we are tracking and creating systems of data management, essentially. And so I do think, number one, take full advantage of what your premium is paying for. So that means picking up the phone and having a conversation with your insurance agent about how their loss control team, and what additional resources your carrier has to support you. You're paying for it. That's part of what your premium goes to. But we also sat down and said, frankly, there's too many moving parts and there's too many people when you consider how many employees we have to not have a system internally that allows us to keep very clear track of all of this information. And so I do think developing a system that works for you, that allows for you, frankly, what we've done is we have an Excel spreadsheet and each injured employee has a tab, and each sheet tracks not only what's happened in the course of the claim, but again, what have we done internally, and where is paperwork? What paperwork has been submitted? That has also been critical in helping us tackle the reporting of our COVID claims. Because once the reporting process, frankly, blew up into what is now required for us in a regulatory perspective, we used the existing system we already had in place to add into it, where we were also tracking the data that we needed around contact tracing, where we were keeping track of information around who those employees, what shift were they on, what location were they at, who was their supervisor at that time, all that kind of stuff. Yeah, and you got to slow down and make the time. And we're in the middle of the season right now. We're blowing and going. And I would say most of the folks that are participating in the call today, this is peak season, depending upon your commodity. And that can be hard. It can be difficult to ensure that you're taking the time to stay on top of things, to review records regularly. But it's also why we've built that rhythm of every Friday at 10 o'clock, that we're going to be on a call as a team reviewing where we're at with claims. What are things that are giving us pause for concern? It was that weekly meeting that helped us realize we needed to go visit this employee in person because the member of the team who'd been trying to reach him couldn't get a hold of him. And so, there's no magic pill or, secret sauce in all of this, but it does require resources, and it does require a commitment from ownership, senior leadership, senior management, however your business is structured, to invest. And my suspicion is for many, that will be one of the greatest impediments.
I love it. Thank you, Amy. Really appreciate that practical advice. We do have a few more questions that we want to get to. Just a reminder to everyone, if you're interested in CEUs, please be sure and include your contact info in the chat box as well. This is a question for Dr. Van. For Amy's case, at what point should he be considered MMI?
Yeah, this is a really good question. So what we see in patients is that, we have that first group that seems to get better relatively quickly. We're seeing some steady progress, and about 4 months, they're ready to go. After that, it gets into much more of a longer term process, anywhere between 4 months to even a year out. And so my thought on this is that once they get into that framework, where the recovery maybe take about half a year, that's when I say, okay, you do need some help with continuing your recovery. It's going to be very slow. There's nothing that I can do in the meantime that's going to quickly lead to your recovery. And that's where I would consider someone to be at maximum medical improvement. Of course, I support them and continue to fly along with them. And if they get some sudden jumps in improvement, something new comes out that helps with their treatment and recovery, then we can adjust those work restrictions. But I would say after that point, if we're into a phase where we're basically just telling them to slowly ramp up exercise at home, there's no acute therapies or the diagnostics going on, that's when we reach that point.
Well, we're all blowing and going, as Amy puts it, which is great. I love that term. I'm going to steal it from you. We're blowing and going. Here's another question. This might be for Amy and for David both, as it may have some legal implications, maybe not. Do you recommend that we do a sort of a wellness check on employees that are back to work that have had COVID in the past year? We'll start with Amy. What are your thoughts?
I have a couple of, I sort of, my instinct is to respond in a couple of ways. Number one, in my mind, well checks for those individuals who have returned to work but have had COVID, to me, that's a good best practice to implement on a couple of levels. Number one, obviously, first and foremost, we as an industry care about our workforce and we want to ensure that their health continues to improve. But also, it's a way for us to spot check and keep an eye or keep tabs on if these individuals are developing late onset symptoms that would be associated with the most common that Dr. Van talked about. But I am mindful, back to my comment previously about how we've been successful around resources. So tackling that in a practical perspective. So looking at, sample set, right? How can you on a weekly basis reach 10% to where over, depending upon how large your operation is and how many individuals within your operation have had COVID, that over, a 1 to 2 month period, you've had a touch point. But certainly also reminding individuals that if they are experiencing any symptoms and have had COVID, that you encourage them to come to you is always a good idea. But as we know within our workforce, this isn't exactly the group of folks that are the first to raise their hands and say, hey, I'm not feeling good. So I like the idea, but I'm a pragmatist in considering where you have the time and the resources to undertake it. It would, my first priority would be obviously your open claims and your active issues, but certainly that is to me, a fantastic best practice to ensure that you're also tracking the potential for any additional developments of individuals who have long haulers related problems.
David, any legal implications with that question, or would you concur with Amy?
There are legal implications, and I'll speak to that from that perspective. And the immediate thing that came to mind is a potential singling out of a COVID employee as opposed to another claimant. And so as far as what you can do, if there's a fitness for duty protocol already established, and that employer has that already established, I don't think that generally speaking, there's anything wrong with having an employee who is maybe in a sensitive position or a safety type of position where them not being fit for duty would cause harm to themselves or to others, where you would follow that protocol. I would be wary of establishing something separate just for COVID claimants, or just for low back claimants, or just for psych claimants, for example, because that can open you up for liability for serious and willful claims. I'm sorry, 132A claims of discrimination. So I think it's a good idea to balance the employer-employee relationship, but just keep those legal implications or those exposure implications in mind.
Excellent. I've got another question, possibly for David and Amy, and certainly Dr. Van, you're welcome to comment on this from a medical perspective. How would you approach a patient who claims they contracted COVID from attending inpatient appointments for their non-COVID workers' comp claim? For example, the patient may say, I know I got COVID from attending physical therapy for my back injury. This patient subsequently abandons care for their back out of fear of contracting COVID again. Why don't we start with David this time?
Yeah, it's a new theory or allegation because this is a new COVID pandemic situation, but it's an old theory in the sense that they're claiming a compensable consequence. So if someone gets hurt at physical therapy or on their way to a medical treatment, the rule typically is that that is compensable. So if they can prove that they caught COVID while treating for another claim, whether it's physical therapy or a doctor's visit, then the general rule is that it would be compensable.
Dr. Van, what is your advice from a medical perspective? How should the employer respond or support the patient in this scenario if they're afraid that they caught COVID while attending their workers' comp compensable claim treatment?
Yeah, I definitely in my career have seen these additional injuries occur during physical therapy. And so my recommendation would be to first keep an open mind, because these things do happen. It is possible that someone could get this at a therapy session. But from my perspective, from a medical side of things with the patient, I would validate that and say that we need all the information that's possible. And I would defer to my legal experts on, how to relate this to their claim and so forth. But I remind them that this doesn't always happen to everybody. Physical therapy offices, despite everything that they do to keep themselves clean and things like that, sometimes there's some variables that we cannot account for. But in the end, what the ultimate goal is to get the patient, the employee, feeling healthy in both aspects related to COVID as well as their back. And we have to keep both of those challenges on the table and help them realize that doing nothing will certainly worsen their outcome. And we can help support them through that as they continue treatment. It won't be a one visit type of scenario though. I often remind people that things in workers' comp, even for the medical side of things, they take up time. They take some reformatting and re-education of the patient in order to make things happen.
A question for Amy. Have you or your insurance carrier considered placing the employee in a return to work program that place employee at offsite locations such as Goodwill, etc., and the restrictions are able to be accommodated when the employer can't necessarily accommodate the restrictions? Have you given that any consideration, Amy?
Yeah, most definitely. And in fact, one of the conversations we even had as a company when we evaluated who our carrier was this last policy renewal period was looking for a carrier who did offer or was willing to provide flexibility around those types of return to work programs. Because previously we had been with a carrier that did not allow for that as part of a return to work or modified duty program. The struggle that we're having is our carrier is in agreement to a certain extent with us around questioning the reality that this employee has even been given these return to work restrictions. So it has definitely been a point of conversation. But because we as the employer are witnessing, again, the severe fatigue and frankly, the ability to converse without having difficulty breathing, we're frankly concerned that anything that involves him being placed in a return to work scenario is going to exacerbate things. And that's been our internal dialogue. Now that, now I'm listening to some of Dr. Van's ideas around having these individuals sort of slowly rebuild. I think we're gonna have to go back to the table and revisit our, how we've been in communication with our employee in terms of thinking through the kind of efforts he's making at home. Because I will be honest, I don't believe that his current medical provider has offered that kind of stair-stepped guidance the way Dr. Van speaks about. And I think that's a practical reality that not all providers are looking at it in the most holistic capacity the way Dr. Van is. And I'm not trying to slam providers. That's just a practical reality. And so the good news is our carrier is open to it, but we're all trying to be really thoughtful about factoring in age and factoring in what we've witnessed firsthand for ourselves is pushing that really at this point in the best interest, or is asking for a revisit of the current assessment more practical.
Thank you, Amy, for that. I will say Dr. Van is one in a million, that's for sure. And I think that, speaking for the community of providers, not just in California, but throughout the world, this is a new frontier for them as well. And so as new emerging research comes out, they try and adapt as quickly as possible. But as you know, getting the data, getting the information out sometimes takes a while. I do want to give a shout out to my friends at the Western Occupational and Environmental Medicine that are based in California. Their providers seem to be on the cutting edge, on the forefront of research for COVID and post-acute COVID syndrome. So hats off to WOMA, and then also to ACOM, the American College of Occupational and Environmental Medicine, which Dr. Van is a fellow of. Speaking of which, I believe you're going to be doing a presentation for ACOM here in the near future, aren't you, regarding post-acute COVID?
Yep. I've done a few of those as well, and I think they're available online. So if anyone would like some more in-depth information about the treatment programs that we have been developing in our process, it's out there for you to see. And the more people that we can get on the same page with the treatment of this in a holistic fashion, I think the better.
Well, thank you all again. I want to give a great big shout out to our panelists and a great big thank you, virtual hug to you each for all the work that you put in to put this together. Putting this together, as many of you know, is not just about appearing the day of. It's a lot of preparation beforehand, a lot of fact checking, a lot of information gathering, and that takes a lot of time. So I really want to say thank you to Dr. Van, to Amy, and also to David. And with that in mind, I'm going to pass the time over to Teresa. Teresa, thank you so much for partnering with us to provide this incredibly important educational opportunity for your members.
Well, Carlos, I just want to kick it back to you and just say thank you so much for your leadership and your vision and putting together this session today. You've really brought this topic to light and giving it the time and attention it deserves. So I'm looking forward to just continuing this conversation. And as we learn more about what's happening with COVID and all of our workers who might have experienced some symptoms and how we continue to care for them. Again, just want to thank you and Risiko for your leadership. Again, SRTK, thank you so much for partnering with us today. And again, thank you to our panel and looking forward to having more of these conversations.
Well, thank you all so much. Have a wonderful rest of your day. And a link will be sent out, I believe, on the recorded version of this information. If you're interested in receiving a copy of the PowerPoint deck, please let us know and we'll be sure to get that out to you. We did receive numerous requests for CEU certificates. We'll be getting those out here in the next 24 to 48 hours. So thank you all so much for participating, for the wonderful questions, and have a wonderful afternoon.
Take care all.